You are now listening to Protecting Your Nest with board-certified family medicine and obesity medicine specialist Dr. Tony Hampton. For more, visit drtonyhampton.com. Welcome to the Protecting Your Nest podcast, where we work together to both understand and resolve the many root causes of chronic disease. There may not be a more direct way to address root cause than to discuss insulin resistance and metabolic syndrome, which may be responsible for greater than 70% of all chronic medical conditions. Who better to discuss this topic than a frontline family medicine physician who uses low-carb and intermittent fasting to reverse metabolic disease? Dr. Andy Phung is board certified in both family medicine and obesity medicine, and he uses functional medicine to help address root causes of disease and to address metabolic syndrome and diseases like diabetes, hypertension, cholesterol dysfunction, obesity, and so many more. His model is a direct primary care program which includes nutrition, lifestyle counseling, in addition to the traditional sick visits we're accustomed to, like physical exams and health maintenance strategies. He's located in Cary, North Carolina, where he is trying to make a difference. He's very active on Twitter and one of the people you should know in the low-carb space. And I really believe that he's changing lives because of that. I've learned a lot just watching his tweets on Twitter. So welcome to the Protecting Your Nest podcast, Dr. Phung. How are you today?
Oh, I am good, Dr. Hampton. Thank you for inviting me to the podcast. And it's my privilege to come and share a little bit of what I know.
Absolutely. Well, we have a lot in common. We're both family doctors and we're both board certified in both family medicine and obesity medicine. So we're essentially twins. We just have different moms, but I think we're really twins. So, because when I look at what you tweet and what I tweet, it's basically the same. So we have a lot in common. And, you know, as any good low carb podcast host would do, I would ask you a little bit about your, what got you into low carb and things like that, and how you're applying those principles to your patients. But before we go there, I want to define a couple of words which I think are critical. And those three words are going to be functional medicine, insulin resistance, and metabolic syndrome. So what I'd like you to do is to help our listeners understand, this idea of functional medicine. I absolutely believe in the principles of functional medicine. In fact, my master's program is nutrition and functional medicine. In fact, that whole NEST and ROPE acronym essentially reflects the model of functional medicine in terms of what the practitioners use to identify the root cause of disease. So if anybody looks that up online, functional medicine tree, look at the roots and you'll see a lot of the things I try to talk about in my podcast and on YouTube. So to get us started, Doc, could you explain what the difference is about functional medicine and conventional medicine?
Sure. I was trained conventionally, go to med school, do residency and all that. And so when we go to medical school, we are taught to listen to the patient, take in their chief complaints and come up with a diagnosis. And after we have the diagnosis is what kind of medication, what kind of procedure, what kind of physical therapy we can prescribe to treat that condition. Versus in functional medicine is, yes, we still listen to the patient and we still come up with a diagnosis, but there's a step beyond that is like, why is this disease or why is this condition come about? And understanding why and the root cause of why, and if we can fix that, it can reduce or sometimes eliminate the disease itself. So the difference is, one, we kind of use medication procedures and things like that to kind of cover the problem. Another one is we find the root cause of it and we remove the root cause and the problem goes away.
That's crazy simple, right? But yet, who'd have thought that us not doing that in conventional medicine was a problem? I don't know that I ever thought that I wasn't getting to the root cause, but I wasn't. And I think that that's why it was so cool when I started my training to kind of see things through a different lens. And although there are times when my education, I don't agree with everything they suggest, but I do agree with this philosophy of saying, why are you sick? And I guess the next term we wanted to define, if you could help us, is insulin resistance. And I think that term is more familiar to our listeners, but I want to make sure they hear from a doc who understands it. How do you perceive that term, insulin resistance?
Yes, I mean, I've never heard of insulin resistance when I was in medical school. I've heard of insulin insufficiency, not having enough insulin. And then, well, actually, I did hear of insulin resistance, but there's nothing you can do about it. But the second part of it is insulin insufficiency. With that said, is insulin resistance is a state where the body makes its own insulin, but what the insulin does, it's a signaling molecule. It's a message that tells the body to do certain things, and the body is not listening to it. Coincide with insulin resistance, or the opposite side of it, is hyperinsulinemia or high insulin. It's easier to understand the problem from a high insulin perspective. But before we tell people what high insulin means, what low insulin means, is insulin is crucial for life. Without insulin, we will die. So for type 1 diabetics, well, usually children where they don't make any insulin, if they don't get insulin injection, they will die. But the problem is we as a society have too much insulin. And insulin has many functions, but the two most common one that is driving the disease process is high insulin promote more fat storage. At the same time, is that when we're storing fat, we cannot metabolize or burn those fat for fuel. So it's critical to get our insulin lower to a point where we can store some energy, but we can also as fat, and we can also use that fat to power us when we're not eating. So, but the vast majority of us have high insulin problem. So that is insulin resistance.
Excellent. And I know for our listeners, I know it sounds like we're in school, but that's what this is all about. So you're doing what me and Dr. Phung have to do. And I think that in order for us to better understand how to take care of ourselves, we have to understand language and terms. And again, some of these terms, as Dr. Phung has suggested, your doc may not be as astute on.
Yes.
So there may be a need to help educate them as you learn and grow. So let's get to the last term. And the last term, which may be the most important, is metabolic syndrome. And although there's a little overlap with those other terms, could you tell our listeners, why understanding and addressing metabolic disease is foundational in reversing chronic medical conditions?
Of course. Metabolic syndrome so the term syndrome is a cluster of things that we tend to find together. And for metabolic syndrome, there are 5 things. First is waistline or truncal obesity. Then followed by elevated blood pressure or on medication for blood pressure. Then the next one is a high triglyceride and low HDL. And lastly is high blood sugar. But high blood sugar is really not a good term. It should be defined as diabetic physiology, because before sugar becomes a problem, insulin itself have been elevated for 1 to 2 decades. So it should be high insulin as part of this metabolic syndrome. And the more of these criteria we meet, the worse the metabolic syndrome is. And so, but what ties all these five things together is high insulin. And then so it's critical to say, okay, if insulin is high, it will drive a high triglyceride, low HDL. When insulin is high, it's going to drive obesity and central obesity, where the fat stays in the middle. And when insulin is high, it drives high blood pressure. And when insulin is high, it drives diabetes. So if that is the case, then all these five things share one common root cause, which is high insulin. So everything we do is trying to lower that insulin level.
I love that. And who'd have known that all those patients of mine who would say they have a hormone problem, we talk about this a little bit more later, but they were right. They do have a hormone problem. I thought they had an eating problem. So it's just interesting that they were right the whole time. So shout out to all the patients who had a hormone problem and the doctors were denying them, because every time you checked the thyroid, it was normal. So we knew, well, you don't have a hormone problem, you have an eating problem. So thank you, Doc, for clarifying that. So I just wanted to take us to school. Thank you. And so we went to school, and as I interact with my guests, I learn so much, and because you express things sometimes differently than the way my brain would have expressed it. So thank you. Now let's get personal. Let's go and talk a little bit about you and your family. And since we're on the topic of metabolic disease, I want to know how metabolic disease has impacted you and your family.
Yes. Okay. So again, I was traditionally trained, diagnose and prescribe. And then so I myself developed a little bit of waistline in the middle, but not much. But I always know that I had a high triglyceride, low HDL. And I was taking medication to lower my triglyceride, and I was taking medication to boost my HDL. But it doesn't seem to do anything. And then a few years ago, I developed prediabetes. And then in between all this, I followed the philosophy of, eat less, move more. If you're overweight, we need to eat less and we need to exercise more. And I have done that twice. Both times lost more than 10 to 15 pounds. But I couldn't keep the weight down, and the weight goes down, the weight goes back up. And when the weight do go down, when I do the eat less, move more, I just get really hungry. And then so I would eat a little bit more than usual, but not like what I used to eat. But the weight just come rolling back. And then so it's very sad when that happened, and you start blaming yourself. Why is this the problem? Why can't you just eat less, and why can't you just stay eating less? Until about 4 years ago, when I heard from Dr. Jason Phung from Toronto, Canada. He's very famous in this space. And he said, look, it's really not about eat less, move more. It's not about calories in, calories out. It's about your hormone insulin. And at that time, I was classically trained as well. So I said, well, I know insulin. Every doctor should know insulin. If you give any patient, insulin injection for diabetes treatment, they will get fat. But I am not giving myself insulin. But how come I'm getting fat and remain fat? And then Dr. Phung went into the three macronutrients, the carbohydrate, the protein, and the fat. And he said, the carbohydrate will drive the insulin the most, and the protein will drive the insulin less, and the fat will drive the insulin the least. And if we're trying to lower insulin, then we need to remove the carbohydrate. And I was like, oh, really? Because I am Asian, and our staple is rice. Every time we eat, there's rice and more rice. Not just rice, but we also have the meat as well. So the idea is that it's really not carbohydrate per se, but it's the carbohydrate going with the fat. So we call them high sugar, high fat, like 50-50, So most people understand high sugar, high fat as the cheeseburger. You have the meat in the middle, which is the fat, and then you have the bun on the outside, which is the carb. But for us Asians, we have a bowl of rice with a piece of pork chop. It's the same thing, high sugar, high fat. And that, the combination drives the insulin the most. And I was like, okay, we have to eat something. We cannot just eat no rice and we cannot just eat no pork chop. We have to eat something. So if we reduce the rice, in this case the carb, then what's left over is the meat, and the meat will make much lower amount of insulin when we eat relative to the combination when we have them together.
All right, so that's interesting because I know a lot of my patients have said, okay, if Asian Americans or Asians can eat all this rice and not, become obese, then why can't I? And it sounds like you're saying that the combinations is what determines what happens, is what's, being combined together. That's pretty much it. So if we don't combine the rice with the wrong things, or if we're living in some small village and we're eating off the land and we don't have to worry about all these other issues, then we can tolerate the rice better. Is that basically it?
No, that's it. So I left Vietnam when I was 11 years old. So I was a boy, but we know a lot back then, and we live on the land. So we grow our rice, we grow our taro, we grow our root vegetables. We eat those, but when we do, we don't have a lot of fat. We don't get to eat meat with every meal. And plus, there's no soda, there's no no cake for you to eat, and then uh, so from that is that yes, we had a high rice or high carb diet, but it's mainly like plant-based whole food, but there was not a lot of fat. There definitely wasn't sugar. And then so that is how a lot of Asians or agricultural people, they still can live on carb, but they are non-processed. Not like what we have here.
Got you. So now you did mention Vietnam. I kind of assumed from your name that would be pretty close to where you're from.
Yeah.
And but is that where you left at 11 and came to the United States, or what were what was going on with your family before Vietnam? Did everybody was in Vietnam and then the United States, or was there any other moving around your family did?
Yes, sure. Yeah, actually, ethnically, we're Chinese. And then so a long time ago, my grandparents moved from Vietnam to China. Sorry, from China to Vietnam. And then they had my parents, and then I was born in Vietnam. So ethnically, we're Chinese, even though we look the same. And then,
Okay.
and
Only
then
you can say that.
I know, we look the
Interesting.
same, but
It is hard. I think as an outsider, it would be hard. But I did, when I was in medical school, I started to get around Asian culture a little bit more. But prior to that, zero exposure, a little bit in high school. And so it takes a while to kind of understand the different cultures. But so you definitely so you have some insights as to Chinese culture and Vietnamese culture, it
yes,
sounds like.
yes,
And
we do. And
then
then,
do me a favor.
sure.
Tell me a little bit about, um, I know that I've heard you talk about that TOFI
Mhm,
concept. Could you
mhm,
talk a little bit about that? Because I know when I was in my obesity boards training, like you
mhm,
was in as well, they talked a little bit about how with Asian Americans, you have to think about the BMI and those things a little differently. So tell
mhm.
me a little bit about what you can tell us about that.
Of course. TOFI, TOFI, thin on outside, fat inside. And so these people are typically, when you look at them, they look pretty okay. And if you stare them in the middle, they might have a very small belly. And that's how most Asians look. And then so the difference between that versus say average Americans, when we look at an average American, they are big everywhere, right? So they are quote obese everywhere. But when we're Asians, when we are obese, we tend to be obese in the middle. With that said, is that we as a culture and we actually as a society values the one who is just a little bit obese. The one who's very obese, they say, oh, you must be sick. What's wrong with you? You eat too much. The other one who's obese in the middle say, oh, you're doing good. Everything's okay. But it's just totally not true. The one who's obese in the middle, TOFI, are at increased risk of diabetes, heart disease, stroke, fatty liver, just like everyone else. And then, but the problem is that we as a society said, look, the one who's very big is just very lazy, not doing what they're supposed to do. That's why they're sick. It is just not true.
Okay, so I get that. So I'm listening to the cultural piece, and I just know, so I'm always fascinated about different cultures. I love to travel, and I learn. First of all, I love to eat different people's food. Let's keep it real. But I also love to travel and to understand the culture differences. And I just want to be clear. So I know you mentioned that for Asians, they can eat rice because they are combining the rice with things that may not affect it. But I know that I was actually on a metabolic multiplier site. And for anybody that's not familiar with that, the metabolic multiplier, they're just out there trying to help docs like myself and organizations spread the message about metabolic disease. And one of the articles I read talked about the CDC report on diabetes, and it said that Chinese Americans as a whole had lower diabetes rates than white Americans. And so I hear what you're saying about the rice, but I'm just wondering, are there any other insights that we can glean from like the Far East Asian culture, whether it's China, Vietnam? What else are they doing different there that allows them to be less diabetic than you would see here?
Sure. So one thing for sure, if you ever go to a Chinese grocery store, say in America, and ask them to make a cake, right? A birthday cake, traditional, carbs and sugar and all that.
Sure.
And then versus the one from a traditional American grocery store, one is very, very sweet. The other one is much less sweet. So as Asians, we don't eat a lot. We don't add a lot of sugar to our carb, at least with the cake. So that's one thing that we don't have a lot. Yes.
Okay.
And then
is that because of access to that, or it's just that's the palate?
I think it's a palate.
Okay, gotcha.
And then so the other one that we also don't have is that at least where like we kind of have to move the Asian American from America. If you go to Vietnam, like when I was growing up, there was no such thing as a snack. There was no such thing as a snack.
Wow.
You wake up, if there's some food, you can have some and you eat and you go to work. When you go to work, you're on the farm and actually work the land and your hands dirty. So you don't get to eat all the time. And so at most of the time when I was growing up, we usually have 2 meals a day. We kind of have a brunch, a late brunch, and a dinner. And after dinner,
got you. Interesting.
So there's no, so we have this kind of like built-in intermittent fasting that we have because we just don't have food year round, like not year round, food all the time. And then so that's the thing. So we don't have a lot of sugar and we don't have a lot of these food all the time. But it's different now. It's different now.
Well, I mean, but doesn't something happen? Because I know that when you get Americanized, right? So do you think that when people, like, how many, does it take 1 or 2 generations for that Americanized thing to happen? Because I think that what I've also read is that when that occurs, then sometimes the Asian American numbers start to lean more towards the American numbers. So what's your thoughts on that? Like how long it takes, or, you know, have
I
you
would,
seen anything in your
yeah,
practice that would help
I
answer that
would
question?
say at least from what I know, we've been into America almost like since '92, so almost 30 years now.
Okay.
So so it takes about one generation,
That's it,
which is
right?
to get sick, and then so my parents were never well, they still alive. They don't have diabetes or pre-diabetes, and but I have it, and then so I would say it takes about 30 years, which is roughly a
Wow.
generation. So
Okay. That's based on your own empiric. Okay, well,
yes.
let's dive a little bit into intermittent fasting. I certainly think it's important. I think since I think for me, I've been in this low carb, high fat space, keto, probably for about 5 to 6 years, and I naturally kind of transitioned to intermittent fasting. And like you, I'm going to call you a famous Dr. Fung, but the other Dr. Fung,
uh,
Fung.
FUNG.
And by the way, he wrote the obesity code and the guide to fasting, but he's the expert on, I would argue, both obesity and intermittent fasting in Canada. And we do all love and respect him. Can't wait to meet him in person at one of these in-person low carb events until, when we start doing that. But the so my question is, for me personally, it's been transformative. Like I haven't eaten yet. I think for those who actually, I take that back. I did eat at 2, but I can go at 2, 3, 4, 5. It doesn't matter. I just kind of do it when it's convenient.
Hmm.
But it's transformed my life. It's probably been the most transformative thing to my patient. So could you just express a little bit about why using low carb and intermittent fasting together are more effective for a lot of patients than just using one or the other?
Of course, yes. And so I use both with my patients. The the key goals is that we need the high insulin, hyperinsulinemia to come down. And then, so if when we do low carb or keto, is that we remove a lot of carbohydrate, and carbohydrate triggers a lot of insulin release. So when we remove the carbohydrate, the insulin level naturally comes down quite a lot. So that's where, so if when insulin comes down, then the body can access its fat storage, like burning fat. But if we have a lot of stored body fat to burn, then really the only time the stored body fat will come out to be burned or metabolized is when we're not eating. And then so, and when we're not eating, it is called fasting. But when we talk about fasting, is that most people think of fasting as not eating for days on end, and that's what we know fasting as. But generally speaking, that's not how long it should be. Usually, anything, if we say eat dinner, say at 6 and don't eat again until breakfast, say at 6 the next day, that's a 12-hour fast. Comparing to traditional Americans, we eat every 2 to 3 hours. We eat, we snack, we graze throughout the day, and that will keep our insulin level high. And when our insulin level is high, it does two things. It promotes the body to store more energy as fat. And while the insulin is up, it prevents us from using that fat to burn or to run the body. So the only time the store fat will come out, in my mind, is when we're not eating. And then so that's called fasting. And it goes by many names. It goes by time restricted feeding, intermittent fasting, and then obviously a longer, like several days, is called extended fast. But that's why we do it, is to allow our body to burn fat, because when we don't eat, our insulin goes low, and when our insulin goes low, it allows the body to burn fat.
Yeah, I love fasting. And your body loves fasting because if you think about it, when you're sick, what does your body tell you to do? Stop eating, right? So
Yes.
it's a reparative. I mean, really, if you're ill, and your brain says, I need fuel and I need energy because that's what we've been taught. But your body just wants to just shut down and focus on healing you. And if it's spending all this energy trying to digest food,
Mm-hmm.
especially if you're I had a patient today who had an upset stomach, and she looked at me funny when I said, stop eating. I mean, it's like a logical thing on one part of your brain, but the other part's like, no, doc, I got to eat because I need fuel. I need to feed my body nutrition. But no, your gut has to digest that food. It has to do work. And if you let it rest, then sometimes that's all it takes. And as I'm kind of sitting here listening to myself, I realize that a lot of the stuff that we do in medicine is simplistic. And even as I think about the next question I'm going to ask you, I'm kind of sitting here in my brain saying, what doctor couldn't understand the simple concept that if I'm diabetic, I should eat less sugar and starch? Like, what's so complicated about that? Who's listening to this podcast right now who doesn't understand that simple message yet? We tell people I remember when the ADA was, and they may be still doing it. I barely look at the guidelines. I'm just saying that out loud. But I mean, half your meal should be a starchy food, and that's your problem. Like, anybody with a brain knows that that's not a logical statement. So, Benny, having said that, I want to ask you a little bit about this idea of, people say, well, I'm going to work on my weight and I need to cut my portions. I need to reduce my calories. That's more important. I think we have a different perspective, and we learned in our obesity training that the macronutrient does matter. So I just want you to speak a little bit about why our listeners should focus not just on, in fact, they shouldn't really focus on calories so much. They should focus on the macronutrient. And which macronutrient do you think is the most important to maybe increase in the diet, or which one do you think we should decrease to get that metabolic health we're trying to achieve?
Sure. Yes. So, we simplify weight problem to calories. We call them, calories in, calories out. If we put in less calorie and we use more calories, we'll lose weight. It's not quite true, because what controls the calories in, like the accessing the calorie once it goes in is insulin. So think of insulin as as something that controls these valves that allows the energy to go in or go out. And then so when we look from that perspective, is that understanding how insulin, in this case hormone, controls our metabolism is much easier and better than looking at how many calories I eat, because it's hard to count calories. And I tried to learn in school, but I was never good with it. And then I don't think most people are good with counting calories. With that said, is that okay, out of the three macronutrients, in this case the carbohydrate, the protein, and the fat, which one will make or promote the body to make the most insulin? Is the sugar. Sugar is nothing but purified carbohydrate. And grains is nothing but sugar, like joining together, like hand in hand, so we call them starch. Sugar, grain, and starch. And so those is nothing but carbohydrate. The thing is that for an adult person, we have 5 liters of blood, which is a lot, literally 5 jugs of blood if we were to drain our body. And in all that 5 liters of blood, there's only 1 teaspoon of sugar, which is about 4 to 5 grams of carbohydrate. And for instance, a banana has about 24 grams of carbohydrate. And then so that is about 6 teaspoons. And then so if we eat a banana and our blood only holds 1 teaspoon of sugar, the math said, where do the other 5 go? And some can go to store in the liver as glycogen, but because we Americans eat all the time, so our liver glycogen is full. And then so that sugar get exposed to the liver, and the liver said, look, we can't leave all the sugar around, so we just turn into fat. And that's what triglyceride is about. Triglyceride is nothing but the new fat that the liver makes from carbohydrate. So when we do a low carb or keto lifestyle, our triglycerides dramatically falls, and then and it goes hand in hand. When our triglyceride falls, the HDL, which is the other good cholesterol, will rise. And then and when we traditionally were taught to focus on cholesterol, the total cholesterol and the LDL cholesterol, as the problematic one, but it actually is the high triglyceride, low HDL, that is much more problematic in causing heart disease. So
That's I literally had a patient today, probably, well, I saw about 18 people, believe it or not, today, because it was, I had to squeeze people in. And one of the things that I use is a virtual note taker, so it's not as stressful. But so we were looking at the labs, and he was like, "Doc, oh, my cholesterol's off. I don't know what I'm going to do." And he had started this whole low carb lifestyle. His triglycerides must have been like 180 when we started. And I looked at his triglycerides, it was like 65.
Wow.
His HDL probably started off at like 40. It went up to like 70. His LDL went up a little bit from, I can't remember the number, but let's just say it went about 10 points. And his total cholesterol went up 10 points. And then he looked at me really funny when I said, "Oh my God, your cholesterol looks great." And it was the funniest thing. And I'm sure you've had that.
Yeah.
And I think that, it's almost like we had to be retrained on how to look at the numbers and understand that the LDL had more to do with the small particle and not the large particle. And I know you do. I've heard you talk about VLDL and all these numbers that we maybe didn't traditionally look at are the things that, so we had to, I think me and you and other docs who have been fortunate to question the failures that we've not been successful with have found a different path. And I really appreciate that education. I do want to, I think about I'm thinking about Dr. Kim Berry. So I had him on, and we both know him very well. And if you don't know Dr. Kim Berry, just go to YouTube and type that in. And he wrote the book Lies Our Doctor, My Doctor Told Me, which is a great book. And one of the lies that I've heard over and over again deals with the fact that our brain needs glucose exogenously to function properly. In other words, we have to consume sugar or starch or things that turn into glucose to feed our brain. So I want you to speak a little bit about that being a lie, if I were to go back to my last guest, and maybe connect the dots a little bit with dementia. I know that there's a connection, so I want you to explain that.
Okay. So it is true that the brain cannot, at least from what I've read and heard, is that the brain can get about 70 to 80% of its fuel from fat and ketone. So the other 20% of it has to come from sugar. So when we eat the standard American diet, which is a lot of carb, is that the brain is exclusively powered by sugar. With that said, is that, what if we don't eat any carbohydrate at all? Like, where will the other 20% of the sugar comes from, right? Because the reason why the brain needs some sugar is because the supporting cells in the brain, the swan cells that support the neuron, needs glucose. And some of the axons, which are the tails of those neurons, are very, very long. And because they are so long and thin, they don't have mitochondria in them. And so when you don't have mitochondria, you cannot burn fat. So that is why the brain still needs some sugar, because of the swan cells and the long axons. With that said, is that we don't have to eat carbohydrate to give the body, to give the brain its sugar, because our liver can turn amino acids, which come from protein, and the backbone, which is the glycerol, from the fatty acid into sugar. It's called de novo gluconeogenesis. And the liver is perfectly capable of generating and making all that sugar for the brain and the red blood cells need to survive. And so the other question is, well, how does high blood sugar, or what happened when we eat a lot of carbohydrate? What is the link to dementia?
Exactly.
So the way I understand it goes like this. So what happened is that the brain is a power hog. It needs food. It needs energy. So it gets energy from two sources. It gets energy from sugar, or it gets energy from fat. Protein, we don't really turn it into energy per se. So when we eat, there's hierarchies in the way the body use energy. So if we have sugar and fat at the same time, the body will always use the sugar first. And then after the sugar is gone, the body will use fat. The problem goes here. So if we eat the standard American diet, which has more than 300 grams of carbohydrate, then the brain will exclusively use sugar as fuel. Okay? But what happened is that after some time, usually decades, the brain's capacity to use sugar becomes less and less. It's just not good at using sugar anymore. So normally, if for anybody, we say, well, if you can't use the sugar, why can't you use the fat? The problem is when we eat the standard American diet, our sugar is high, but now the brain said, look, I can't use the sugar very well. But at the same time is that the insulin level is also very high as well when we eat the standard American diet. So we can't even access the fat stores. So what happened is we are depriving our brain of energy from sugar. It's not that we don't feed it, it just can't use it. But then because of a high insulin, the brain cannot access the fat store. So what will happen to the brain in this case? It doesn't have energy from sugar. It doesn't have energy from fat because of the high insulin. So the brain literally shrinks. And when it shrinks, that's what Alzheimer's is, losing your mind. So
Wow.
yes.
I love
So
it.
so the
I mean, because
question.
when we look at MRIs, that's what we kind of say. Oh, your brain's shrinking, and we never. Um, I'm be honest with you, Dr. Fung. I knew this, but I've never heard it explained like you explain it. It makes sense logically, right?
Yeah.
So it's like that's why this is incredible because I've never heard it explained like you explain it. So I appreciate that. But you can go ahead.
You're welcome. And then, so the question is, well, if I eat this standard American diet, high sugar, high fat, that's damaging my brain, why or how, if I eat a low carb, a low sugar, high fat, that will actually help my brain because we're changing the fuel source. We're not, so we're basically, the brain is dependent on sugar in the past. We're like, look, we're not going to feed it sugar. So if we don't feed it sugar, then we have to feed it protein and fat, which makes much less insulin. So when the insulin becomes less, the body, in this case the liver, can turn fatty acid into ketone bodies, and ketone body can crosses the blood-brain barrier. So now the ketone body is fueling the brain with a different source of energy. The brain, to be honest, it doesn't really care whether the energy comes from the sugar or the fat. It just needs the energy. But when we eat the standard American diet all the time, is that it just gets damaged. It can't use the sugar, but it cannot use the fat. So basically, we are changing the fuel source when it's powered by fat.
So this gives some people hope about this very difficult conversation around dementia. So I guess, would it be fair to say, in my clinical experience, say you got to catch people at a reasonable point. If you catch them when they're walking out the house and wandering down the street, there's benefit, but it's
Mhm.
not going to be as great. So what's been your experience about when you can actually get people early enough to impact their dementia with dietary changes?
Yes, I actually had a person a few years ago who had pre-diabetes, and it's a family, like siblings. There are four different siblings, three sisters, and that my patient. And then all the sisters are in nursing home already because their memories are no good. And then but he is the last one, and then he starts, having behavior problems. And then what I know at that time was he was having pre-diabetes. Insulin level was going a little bit higher. He was carrying the fat in the middle. So I told him, like, look, you need to probably treat your pre-diabetes, going a low carb. And then so what happened is we get him to do low carb, but then he stopped a few months later. And why did you stop? He said, well, I don't know if I would like to do that. And then, in this space as doc, as you know, when you learn one thing, you learn another thing. So a few months later, I've heard that, hey, low carb is not only helping with pre-diabetes, but low carb can help you with your brain problem. And so I got him on low carb and fasting, and he lost about 40 pounds. Within those 6 months, so before he went on low carb, he was, having lots of memory problems and had to come to the office with 2 chaperones because he was acting out and things like that. Within 6 months, he lost 40 pounds. And after that, he drove himself to the office without any chaperone.
That's insanity. I mean, I don't even know what to say. That's like a miracle.
It is.
And, you know what I mean?
Mm-hmm.
It must have blew your mind too.
It blew my mind.
It's like what you know, but to see it in action, people think that you'd be making this stuff up. That's crazy.
The key, doc, like you said, is you want to catch them early before they are in the nursing home. And so
right.
the best way to catch these insulin resistance, whether it's the body or the brain, is to measure your insulin level, right? So,
right. I did a video about the HOMA-IR calculation, insulin times glucose divided by the constant. And anybody can look that at HOMA-IR. And you can just do an insulin fasting level. And as you've suggested, yeah, I mean, if your incredible pancreas is doing its job well, it'll keep the blood sugar looking normal, but it's got to do the work. And the insulin level is going to be high way before you become diagnosed with diabetes. And obviously, type 3 diabetes, which is dementia in some people's eyes, it does the same. So what you're saying just gives people hope, because if you're listening to this podcast and you're hearing type 3 diabetes equals dementia for the first time, you're hearing what Dr. Andy Phung is saying, and you're like, what about my family member? Well, there's things you can do. And I think, what I'm going to do is I'm going to reach out to one of our good friends on Twitter, Amy Berger, and we're going to get her on the show because and she wrote the book, by the way, The Alzheimer's Antidote, and she uses this methodology in her research. I think she actually was doing her thesis or something like that, and that she took this subject on, but she became an expert on dementia and found that dietary interventions can matter. So if anybody's wanting more, besides me trying to get her on as a guest, I would actually get her book, The Alzheimer's Antidote, and it'll provide at least some actionable steps that you can take before you or your family member are in the nursing home. So I just wanted to put that out there. There's another book I can't think of the author, but there was The End of Alzheimer's.
Del
There's another.
Bredesen.
Yeah, thank you for knowing that.
You're welcome.
And that book is more of a functional medicine model, but it's the same stuff. So there is hope, and the medicines. Did you make a comment on the medicines? Why aren't the medicines working?
The one we have is like the Aricept and Namenda, and then so when people have progressed long enough, when we start them on those medicine, it seems to slow down for a few months, but it always gets worse.
Yeah.
So the problem is that it's not a lack of Aricept or Namenda. It is the insulin resistance of the brain. We need to fix that in order for that to stop, right? I mean,
Yeah.
so.
I think that's it. And it's so funny because people may say, well, how did we go from talking about, insulin resistance, metabolic disease, and we're talking about dementia? Well, because it's all the same disease. And that's what we didn't learn. We didn't learn this in medical school. We learned those things as separate entities, completely unrelated. And as we've re-educated ourselves, we're like, oh my God, they're the same disease. And what I like about functional medicine is that sometimes if you're not sure, how about if we just optimize your health, right? And if we
Mm,
optimize your health, a lot of times all these other things get better, even if you can't explain why. So
mm,
for me, it's like, and that's why when I looked at your website as I was researching you, I was very happy to see that you are into optimizing people and so that they won't get sick in the first place. So,
mm,
and speaking of, when you're sick, this idea around disease reversal. So when I wrote Fix Your Diet, Fix Your Diabetes, I wrote uh, it was the dietary approach to reversing diabetes. And I wanted to say cure. I didn't have the courage to say that, so I said reversing. And some of my colleagues probably looked at me funny when I put reversing because we were trained that it was a progressive disease. So I guess my question to you is, you don't see anything about this ideal about disease reversal in the mainstream media. You will see it on Twitter with where we're at. You will see it on a podcast show like
uh,
this. But what do you think about that? And why aren't people talking about this? You just gave us a miracle, right? You just gave, without medicine, you gave us a miracle story, and yet it's not on Fox News or CNN or MSNBC. So why do you think that is?
uh, um, I think because everything we do in medicine, especially regarding nutrition, is so wedded in keep our calorie very, very low. And then so because of that, what we are doing is that we are avoiding the natural fat. So when we're avoiding natural fats, what do we eat? Is carbohydrate. So and then even the guidelines they might say, well, don't eat sugar, which is really bad, but you can eat whole grain or you can eat lots of fresh fruits. Well, that is nothing but sugar as well. Once you eat it, it turns to sugar. So, and this is the guideline again. Don't eat fat because fat has too many calories. Eat eat whole grain. Eat small meals. Eat multiple meals a day, and do your exercise. And then, but the problem is that the exercise is fine, but the problem is we can't outrun a bad diet. And that is a terrible diet for the vast majority of people when they have insulin resistance already. So that's why if we follow the guideline, eat whole grains, eat multiple meals a day, and then eat low fat, we're not going to find the answer. So when we don't find the answer, is that the disease gets worse and worse over time. And so that's what we're taught in school. Once you have diabetes, it will be with you forever. Once you have high blood pressure, it'll be there forever. It's the same thing because our nutrition is wrong. And when our nutrition is wrong, everything else are just giant band-aids, one after the next. So
Wow. Okay. That sounds fair. So I I wanted to just ask this. This is almost a question for me because when I have been interviewed myself, people ask, well, why are you in this space? And I talk about family being affected, but I also talk about how I had, a stomach issue, probably more of an irritable bowel. And then when I made these changes in lifestyle, fasting and low carb, etc., it just kind of went away. But I know on your website, it talked about mitochondrial dysfunction. It talked about leaky gut. And I'm just curious. I know we weren't trained. I don't know about you. I don't remember hearing about a leaky gut.
no.
Uh, so I want you to just connect the dots a little bit because I know we're going all over the place, diabetes, and we're talking about the brain, and now we're in the gut. But I want to connect the dots with the gut a little bit too, and how that's important.
Okay. So um, so the mitochondria. So basics. Mitochondria is we call them the powerhouse of the cell. What it means is that mitochondria is what the body uses to turn sugar or fat into energy called ATP. And what the mitochondria is made up of is wrapped around called the envelope. So that is called a bilipid membrane layer. It's made of fat. So in mitochondrial dysfunction is that the lipid that is made up of the mitochondria is not made out of the fat that is good. So there are different types of fat that we eat. There's the saturated fat, then there's the monounsaturated fat, and there's polyunsaturated fat. And then under the polyunsaturated fat is that the vegetable oil is one of them. And the vegetable oil is really not, so when we eat a lot of junk food, it's cooked in the vegetable oils, and that vegetable oil, that fat, get incorporated into the membrane of the mitochondria. And so think of the membrane is not made up of the ideal material. It should be made up a lot of saturated fat and cholesterol, but right now it's made up of a lot of, we call them PUFA, unsaturated fatty acids. And then so the membrane is made of weaker material. So now you're asking like think of the mitochondria like an engine. Think of an engine that is made of shoddy material that's trying to make a lot of power. It will run hot all the time. And when it runs hot all the time, it generates something called reactive oxygen species. And that's what damages the mitochondria. So, but how is that related to leaky gut? Well, it might not, but the leaky gut comes through a different mechanism. When we eat food goes to our intestines, and depending what we eat, the food have to come across the intestine by absorption. So when we eat sugar or carb, it gets break down into glucose. When we eat protein, it gets break down into amino acids, and when we eat fat, it gets break down into fatty acids. So those molecules actually will diffuse or carry across the stomach lining. But in leaky gut is that there are certain proteins that we eat, such as as gluten in wheat or gliadin in wheat. Those have a special name called lectin. These proteins, when we eat, they don't get digested into the individual amino acids. So these proteins, they would be kind of like moving around the intestine, like the wall. And what they do is they trigger the intestine to produce something called zonulin. Zonulin is a key that opens up before the key, then what happens is that the intestines are lined by individual cells that are locked hand in hand. We call those tight junctions. So when these undigested or not undigested, incomplete digested proteins that mainly come from plant food, that triggers the zonulin release, and the zonulin is the key that goes and opens up all the tight junctions. And then so what happens is that it creates a gap between those cells, and so now other protein that are in our food or the bacteria and viruses that should be kept out are being exposed to our environment. In this case, the autoimmune environment, and that is what triggering a lot of the autoimmune diseases that we have, because certain proteins that we eat that come from the plant food is triggering the gut to be very leaky or permeable, and there are other proteins that comes through and that drives the autoimmune disease problems that we have.
Wow, so many connections. In functional medicine, in my training, they call it the interconnectedness of life and how everything's interconnected. And for those listening, that may be the reason why you literally can't depend on a chemical because it's interconnected too,
Mm-hmm.
right?
Yes.
So if I take the nutrient out of an apple, if I'm more of a berry guy, but let's use the apple as an example,
Uh-huh.
and I identify what that nutrient is, and I try to put it into a pill, and then I enter the body, it may not work as well because there's other things within that apple that need to work together
That's
to
right.
help you achieve optimal health. So I think that interconnectedness is so important, and that's why we are going to be on a journey. When we're long gone, the future scientists and future generations are still going to be trying to figure all this stuff out. But I think the bigger message is if you can just be as, whole food oriented as possible, and use common sense. If I eat a grain that's got 40 carbs, that wouldn't make sense for a person that's trying to avoid diabetes. That's just common sense. So use that. So I just appreciate that. And speaking of all this education, I guess what I want to ask you, if I have any clinical docs
Mm-hmm.
listening in particular, what would you say about this ideal of us becoming board certified in obesity medicine? Do you really feel like that really added additional value to because you kind of knew a lot of this before you got into the space, but you wanted to get that. So why would you even bother getting that additional designation as a board certified obesity doc?
What do you call them? Initials makes a lot of initials gives you credibility, right?
Credibility. That's right.
And
You get a
then
chance to go to podcasts, right?
that's right. But with that said, is that all jokes aside, there are not many obesity doctors around, and we have an obesity epidemic in America, and then so more of us are exposed to it, then we can help a lot more people. With that said, is that uh, it's you probably don't need obesity medicine board certification to teach the patient's nutrition. But with that said, is that we taught nothing about nutrition in medical school. So learning a little bit, trying to get the board, or do a lot of listening will be very, very helpful to help our patients.
All right, I agree. And I know for me, it's been very helpful. And it's nice to go back a little bit and learn
Mm.
some hormones that I hadn't heard of. At least I'd say I'm not making this up, probably 70% of those things in the gut and brain, those hormones we had to learn, and neurotransmitters, a lot of stuff I hadn't even heard of. So
Yeah,
I learned a ton. So I may not apply them every day in terms of my interactions, but it's nice to be able to speak to those things. Some of the stuff you just shared with us got a little academic, and I think you wouldn't know these things if it hadn't been for some of that additional training. So I appreciate you sharing that, and hopefully somebody's inspired to consider this. So well, I guess I'll get to that question I like to ask towards the end, and that's real simple, and that's that personal question, going personal again, and that goes back to the nest and the rope and nutrition, exercise, less stress, more sleep, how you think, trauma, and of course, relationships, organisms, pollution, how we are dealing with our emotions and our life experience. So when you think about all those things, and over the next year, what do you plan on focusing on yourself?
uh, so I think I'm pretty good with nutrition, which is the most important part, by the way, what we
Yeah,
eat and when we eat. I'm doing my exercise. I do a lot of the body weight exercise. So I don't go to the gym. I do push-ups. I do chin-ups. I do other things. Um, I do try to sleep. Get 8-9 hours of sleep. I think positive thinking at the thinking part. With the COVID, with the economy, and with everything else,
that's right.
it drags everyone down. Yes, it drags us down as well. And then so trying to look at from a different perspective is helpful. And then as far as the relationship goes, my wife would tell people that I have my temper is not the best, and then so I try to have a little bit longer fuse with with things, but as you probably know, as doctors, we're kind of anal and we're kind of like
Right.
get things done, get it done
That's
now.
right.
So sometimes that I think doing a lot of that will be very helpful, and then so certainly with life experiences, the more we do it, the better we learn. And then
Man, you
so
preaching to the choir
I
with
mean
that one.
it's just there's no substitute in learning. You just have to do it. So
That's right.
yes.
I think as long as you want it, it'll come. And I do agree with you. I'll probably be a better podcaster in a year. I'll probably be a better YouTuber in a year. I'll probably be a better tweeter in a year.
Yeah.
And I think you just have to do it. So I really appreciate you coming aboard and spending some time with us on this podcast episode as we try to teach people how to protect their nest and their rope. And I also appreciate and will ask you to spend a few minutes with me as we go Facebook Live. That's my kind of tradition for those who are crazy enough to do it with me, just to, again, introduce you to that audience. And for those who are listening, who hear this podcast, if you go to YouTube and look for episode number 6 with my friend, Dr. Phung, you'll also see an interaction. And Dr. Phung was fortunate enough to share some slides of a testimonial story. And so you'll get a chance to hear, kind of an example of what's possible when you take on this lifestyle. So thank you again. And I'll wrap up with the following. And I was thinking about what we talked about today, and we went to school, and thank you for taking us to school, Doc. I was taking notes. Functional medicine was defined. Insulin resistance was defined. And of course, what we feel is the most important thing is metabolic syndrome. And I mentioned the metabolic multiplier. So if you just Google metabolic multiplier, that'll be a site that may add value for those who are listening. Dr. Phung shared some personal insights about his upbringing, his family. Also rice, and why rice may affect us differently based on what we combine it with. We talked about macronutrients and why fat's not such a bad thing, and why carbs may be harmful if done in excess, to grains if done in excess, although I think on these two guys on this podcast avoid those things a lot more than just a little. And I think those who are concerned about dementia know a little bit now that we're going to try to get Amy Berger on to talk about dementia in more detail. And then we lean our colleagues to provide value. We talked about leaky gut, and what you found is that some of this stuff, you're like, first of all, what's leaky gut? But I think the big message for us is, metabolic syndrome will answer a lot of questions.
That's
So
right.
we want everybody today, and that's why I titled this Metabolic Syndrome, because I felt like that's something people need to know about. So you've learned a lot. We've shared a lot. And I think that the more we learn about metabolic syndrome, the more we'll be able to help us all walk towards achieving our goals. So with that, thank you for listening to Protecting Your Nest with Dr. Hampton. And as I always end my podcast, be safe, be well, and continue to protect your nest. You've been listening to Protecting Your Nest with Dr. Tony Hampton. For more, visit drtonyhampton.com.